All right, folks. Well, it's Healthcare Unfiltered, and I have two new guests on this podcast that, if they play their cards right, they could be invited again. So we'll have to see how that actually goes. Today's podcast, we are going to focus on a couple of things, but really, it's a dermatology podcast. It's skin disorders podcast with a little bit of a twist on disparities, and this actually the idea came up for various reasons, but really what sparked my interest in doing something like this is I was having a conversation with a colleague who about melanomas, and there's really the assumption that melanomas only occurs in fair-skinned folks, and I really felt that there's probably a lot that we could do on this podcast just to explain some of the advances in cutaneous diseases, and then a little bit of a twist in terms of incidence and how this could affect really anybody, and probably some of the risk factors differ between folks. And to do this, we have two amazing guests that introduce themselves, but with different specialties. That's why I really wanted to do this. So we'll start with Sue Park. Dr. Park, introduce yourself just a little bit to listeners and viewers of Healthcare Unfiltered.
Yeah, thanks so much. So my name is Sue Park. I'm an associate professor at UC San Diego, and I'm a cutaneous oncologist. And I'm really glad to be here today with you both.
And Sue, you're a medical oncologist by training.
Yes, medical oncology.
Right. And my listeners will now understand that it's not a coincidence that the two guests I have today, they live in California, where the sun is always there, and the topic is about skin stuff. Farah, please introduce yourself.
Yeah, my name is Farah Abdulla. I am a dermatologist, dermatopathologist, and cutaneous lymphologist by training, and currently the senior medical director at CARES.
But your training was a little bit different than Sue, right? I mean, like Sue obviously did internal medicine, medical oncology. You went through the dermatology route, and then you had an interest in dermato-oncology, which I really think will make this is a very interesting conversation. So I mean, there's a lot that has over the past really 10 years or so many advances happened in melanoma. And during my training as a resident and a fellow, I could never forget how awful this disease, when it metastasizes, was. And it's almost becoming like a chronic disease, not quite, but hopefully we're heading this way. But before we get some of the new treatments, I'm curious about, when you think of melanoma, we'll talk about melanoma, non-melanoma, and we'll talk about non-cancerous diseases. In melanoma, what's the notion in terms of, how this happened in various races and ethnicities, like between folks who are dark-skinned, folks who are Asian, folks who are from Africa, because there's a lot of this that folks may not really know.
Yeah, no, that's a great question. I think a lot of people, associate the development of melanoma with sun exposure from UV radiation. And there's a lot of data that supports that. I think that data is more stronger in non-melanoma, but there's other types of melanomas that are not associated with sun exposure. And those tend to occur more commonly in the non-Caucasian populations. And so there is disparity in melanoma care across ethnicities and races. And, but we have treatments for all these types of melanoma. And, melanoma treatment has changed a lot since 2010. And so I think educating everyone about the different types of melanoma, not all melanoma is the same, not all melanoma is driven by the sun, is really important.
So, and we'll go over that, but Farah, can you do anything to prevent melanoma?
I mean, the sun-driven melanoma, yes. And I think the problem that we have from the dermatology perspective is people still think that if they have fair skin, they're the ones who have to use sunscreen. And so we have quite the disparity in education of people who have darker skin colors or darker or higher numbers of Fitzpatrick skin type, because we're not reaching people well enough to say you also need sunscreen. I also think lately it's been kind of nice though, because sun protection has also I think people are recognizing it. Before, like, there was a lot of, I can't wear this sunscreen wasn't made for my skin, I can't protect my skin. At least now people are realizing, despite their skin color, they should, and that there are newer products that are coming out that are actually made for the darker skin types as well.
So let me understand this just to understand. So there's a sun-related melanoma and a non-sun related melanoma?
Correct. Yes. And I think most people think that it's always sun related. And so because they believe it's always sun related and it's only people who would tend to sunburn like lighter skin types, that's where we have a problem. Is that it's like explaining to people that not all lung cancer is caused by smoking. I think it's the same thing. It's like there's a common cause, but there are also other causes that when you add them up are as significant as the most common cause.
So what are the non-sun thing, like the non-sun things that may lead to melanoma? So I mean, just randomly, it could occur regardless of sun exposure at all, right?
Yeah, so I mean, there are genetic reasons to develop melanoma, as I believe Sue was alluding to, but also now we deal with a significant immune suppressed population as well. So maybe it could have been sun-related, but your body could have taken care of it. Now, because we're suppressing your immune system, you're more likely to not be able to undo the multiple hits you're getting. And it can progress more quickly, and it can progress in cases where it wouldn't have before.
So for the sun-related melanoma, all what we could do is I don't know, avoid sun and put SPF on, whatever, right? These sunblocks, they have different grades. They put 15, 30. I mean, how much of this is a marketing thing, or really this higher number protects more than the lower number?
So I am not an expert in SPF like I think Farah is, but what I've also been told and what I've learned is that I think a minimum of SPF 30 is what we typically recommend. And I think the more important thing is to let patients know that you can't just apply it once. It doesn't last all day. You have to reapply throughout the day, especially if you're also in the water or working out heavily and sweating a lot. And there are a lot of great products out now for patients with darker skin tones. I recently told one of my patients who is African American about a website I found called like Black Girl Skincare, and they have products that are specifically for darker skin tones because some of the sunscreens can make darker skin tones look really ashy. And so there's now like sprays, there's like, lotions, there's creams, there's all different types of ways you can apply sunscreen. So I think it's just really important to tell patients, find the product that works best for you and the one that you're most likely going to apply and keep applying.
But then the non-sun related melanomas occur more in non-white, non-Caucasian patients, or it doesn't matter?
No, so the non-sun melanoma, so like you can get like an acral melanoma, a mucosal melanoma, those occur with more frequency in the non-white populations, like the Hispanic population or the African American population. And for those patients, because it's probably not sun related, it's really important to do skin checks at home and also to really get education from not only dermatology, but your primary care doctor, that if you find an odd skin lesion in an area that doesn't see the sun, that doesn't go away, you should really let your primary care doctor know so you can get it checked out. A lot of patients might not know that you can get these other types of melanomas, and they see a lesion on the bottom of their foot and they don't think about that it's anything, but those may turn out to be a pretty deep melanoma, and we have treatments for that if found early.
So is it the same issue for the non-melanoma? For listeners who are listening to this, there are other types of cancer that are not melanomas, like basal cells, squamous cells, these ones that frankly most people, the general population, don't think much of. Like, I had a squamous cell, what's the big deal? I've had a basal cell, what's the big deal? So Farah, is it a big deal? Like, do we undermine a problem, or like what are your thoughts on, and I'm sure you've heard that from other people.
Yeah, I think so. I'm going to start out with my view is skewed because I often see the ones that do end up becoming something, having usually always worked in cancer centers. So yes, we're lucky. Most of the time, a BCC or an SCC found early is usually indolent. The times that we get really concerned are, we have people that it's out of sight, out of mind. Oh, it's there, it's crusty, it's a little red. And then they just let it go and let it go and let it go for years. And you take a potentially treatable problem and make it untreatable. We also do have issues again where most SCCs are sun related, but as Sue can tell you, a lot of times we'll find that it's actually HPV related. And then that becomes a really big problem in people who are immune suppressed for various issues, whether
The
it
skin
be,
stuff HPV related?
yeah, like not BCCs, but SCCs or squamous cell carcinomas can be HPV related and driven. And that really becomes an issue if you're on a drug for an autoimmune disease that suppresses your immune system. If you've had a transplant, whether it be a renal, a lung, or hematologic transplant, those cancers need to be seen sooner. And luckily, the sooner they're seen, whether it's HPV driven or whether it's due to sunlight, can be easily treated quickly in most cases. But they need to be seen and treated quickly and definitively sooner rather than later. Otherwise, we're seeing a lot of cases that then unfortunately you are passed from the dermatologist to the oncologist to do more than what most people know of for skin cancer, which is either scraping it or cutting it out. Then you're seeing an oncologist for actual systemic therapy.
But these ones, Farah, they only happen because of sun, or do they also, like melanoma, have non-sun related causes?
Both. So they can majority happen because of sun, but they can also happen
You
due
mentioned the
to
HPV one.
non-sun related causes. And so for SCC, HPV is a big driver.
And so the same question, I mean, the non-melanoma stuff, if you're African American, if you're Asian, if you're Hispanic, do you worry about these things as well as a possibility, or it's not as, I'm sure it could happen, but I mean, how do you see this compared to the melanoma in the non-Caucasian population?
Yeah, so non-melanoma is mostly driven by the sun, but like as Farah mentioned, I see a lot of solid organ transplant patients who are all different types of races and ethnicities, and they really need close skincare follow-up because the medicines they're on put them at increased risk for these non-melanoma skin cancers, which can get pretty nasty when you're on these immunosuppressive drugs. I do also see, I have a fair number of patients that even though they're non-white, they do have non-melanoma as well. So I think it just goes to show that, skin cancer doesn't really care what color you are. It's just really important, especially if you have additional risk factors for skin cancer, to just get plugged in, with a dermatologist or your primary care doctor. Because the earlier we find these skin cancers, people like Farah can treat them. But if they advance really badly, then you need to see someone like me. And fortunately, we have a lot of good treatments now. But if you're in the, solid organ transplant population, that's where our treatment is still limited. And so, we're still doing a lot of research to, find better treatments for those people.
Farah, I mean, I'm sure all of us, like the three of us, have always, sometimes a friend of yours stop you, a family member, hey, can you just take a look at this spot or wherever it is? And, we all have some of these, like, tiny things sometimes. And you can't really keep running to the doctor every time you see something. So is there anything that just should make the person a little bit more alarmed, because we all have these tiny things in our bodies?
Yeah. I principally tell people if it's new and it's growing quickly, and by quickly, I mean like within a month or two, you're seeing a change. That's something you should definitely show to your primary care doctor. I think that also, when we're going for our yearly physicals and the doctor says, please get into a gown and let the physician take a look at you from head to toe. One thing actually that Sue was mentioning is like mucosal melanomas, right? So people think, oh, skin cancer, I just need to look at my skin surface. But I can't tell you the number of times people have things growing in their mouth and you don't know because you don't look in there regularly. So letting a clinician take a look at areas that are difficult to see, like behind your ears, your neck, the back of your neck, meaning inside your mouth. I think those are really important. Besides things that are growing rapidly, if things are bleeding, if things are painful, definitely showing them to a physician. And I think we live in a day and age where it's become easier, meaning that if there was one upside to COVID, it was that we really now do teledermatology. So taking a picture and emailing it to your clinician has become much easier and should be utilized as much as possible. I know that when I look in my physician's portal, there's always attach a photo or attach a document as an option. So if that's something that, it can give you real it can give you peace of mind sooner, but it's also great for the clinician to be like, yeah, it's worth a drive in. You really do need to come in. I really do need to take a look at this. This really does need to come off. So,
Okay, can I tell you the biggest problem that patients face and people face with dermatology?
I'm sure
It's
I think I know what it
impossible
is.
to get in to see a dermatologist. I
Yeah.
mean, honest to God, I mean, I know this is not the topic of this conversation, but
No, but
some of my listeners are going to say, okay, and then they'll call and they'll get an appointment May 2024. I
no,
was
that's
trying to
very true.
help a colleague of mine to get to see an allergist, and she called in mid-September and she was given March 2024. And a primary care, I mean, they said sometimes they're just not to call, like we'll call you and you'll never hear back. It's really a problem. I mean, it's honestly a big problem. And I have to say that oncologists probably do the best in trying to get people in because we have to, but some of the other things, I don't know how we solve this problem. That's probably another topic for a completely entire podcast.
Agreed, very much.
So let's go over treatment a little bit. So when it comes to melanoma, you mentioned that over the past 10 years, I mean, things have changed significantly. How so? Like, what should somebody who has an early melanoma expect, and somebody with a late melanoma or metastatic disease expect nowadays?
Yeah, so for early melanoma, most of those patients will see Farah, and then she may refer them to another surgeon, or she may be able to advise them on who else they need to see. But even with early melanoma now, a lot of the treatments that we have for advanced melanoma are moving to earlier stages. And so I think that just really highlights the importance of clinical trials. We didn't have all these new drugs for melanoma that I'll touch upon in a little bit if it weren't for clinical trials. We had these clinical trials starting in like 2011. And since then, we've had so many drugs approved and they changed the lives for patients with even, metastatic melanoma. We have these patients living, 6-7 years out now. So for late stage melanoma or advanced melanoma, you typically see an oncologist like me, and we will often, send your tumor for, sequencing just to see, what other characteristics there are. But we have a lot of treatment options now. We don't use chemotherapy anymore to treat melanoma. That's back in the day. So we'll use immunotherapy, which we got through clinical trials, or we'll use targeted therapy. So we have pills that can work for some patients if your melanoma has a specific mutation. And sometimes we can, sequence these in a different way. Sometimes we also have injectable drugs now that are approved for melanoma that we use in certain situations. So the landscape has really changed.
So in early stage, when patients are resected, do all patients require additional therapy after resection, or some patients you just resect and don't do anything after that?
Yeah, so a lot of patients, they just need resection, and sometimes they'll get a sentinel lymph node biopsy, and if the pathology looks okay, they should just, see their dermatologist on a regular basis just to make sure they get regular skin checks. But even nowadays, we now have immune therapy that was only approved for, metastatic patients, and we're moving it into earlier lines of therapy to the point where, some of these patients, it may be appropriate for them to get 1 year of immune therapy after surgery, even if it was considered to be more of an earlier stage.
And Farah, let's shift a little bit to, I want to go to metastatic disease in a little bit. I want to go to the basal cell and the squamous cell. If you're able to remove, you remove and you monitor, right? There's nothing you do afterwards in terms of surgery, regardless of how big it is?
Well, regardless of how big it is, you always have monitoring. Now, the guidelines aren't very clear on how often to monitor, and so often it's left up to the dermatologist to very much personalize that follow-up monitoring with the patient. So, for instance, if I get a patient who maybe has one basal cell and doesn't have a lot of sun damage, I can probably for the first year see them a little bit more frequently. And if they don't have any new lesions and they're really good about sun protection, it can probably be yearly. But then I have patients who have significant sun damage. Every time I see them, they've got a new skin cancer, whether it's a squamous cell or a basal cell. And those people I'm probably going to see every 3 months and very regularly, because they will probably have a skin cancer in an area that's not detectable. Almost everything they have really does need biopsy. And then we're also entering a new phase for them of chemo prevention, meaning like using topical chemotherapies to try and prevent precursor lesions that could lead to full
Right.
skin cancers.
Right.
So it's really, I think the difficulty in providing guidelines for follow-up and detection are there because the variability in people's sun exposure, skin type, and follow up on their own of like using these sunscreens and sun protective clothing are so variable. So it's really, really has to be personalized between the physician and patient.
So, are there any known differences in outcomes, responses based on race and ethnicity? Or is it just not studied? Like if everything is the same, so you have the same access, we're not talking about, you can get the drug, you can undergo surgery, and you can undergo monitoring. If you have all of these equal, do we know if there's any differences just simply because of some whatever characteristics that are based on race and ethnicity in melanoma?
I don't think we know that information as in much detail as we would like. But if everything was the same, meaning access to care, access to specialists, timely access to immune therapy, then I think the outcomes should be relatively the same. But I think we're still doing a lot of research as to whether, any genomic or genetic differences based on your race or ethnicity do influence your outcomes. But if everything were the same, the outcome should be the same. But we know that there have been recent studies where, we know the outcome is not the same because of access to care.
Yeah, I mean, I was wondering, like, if there's like a, I don't know, a mutation, a biomarker, like something on the genetic level that may actually lead to resistance to a particular therapy or something of that nature. But I don't know. That's what I'm asking.
Yeah, we're hopefully, we're still doing a lot of research in melanoma now, and I think that's one of the areas that a lot of people are focusing on.
Farah, same question in basal cell and squamous. Do we know, I mean, African American, let's say, versus Caucasian differences in outcomes? I don't know.
I think the issue here is that the majority of skin cancers, regardless of race, are usually early stage and
Right.
so are removed surgically. And so there aren't a lot of studies across the board in general doing genomic sequencing to look at that. Like even some of the things that are on the market are very limited in profile. So there's a real kind of tug there of like what is going to produce financial toxicity versus what's not. So even just like sequencing on the very basic level is difficult to do in any population just because we have easy go-to therapies. I was going to say, compared to metastatic melanoma or just advanced stage melanoma, where there is a lot of sequencing, we actually don't have a ton of sequencing done in advanced stage SCC. So there's no real targeted therapy there in general for any population. I mean, there's immunotherapy, as Sue can tell you, but beyond immunotherapy, there's nothing. That even isn't even really targeted. We're looking at what, like PD-1 and TMD, but we're not looking beyond that. So I think it's a real struggle to even justify looking at targets in general for any population, which I would hope would actually be the next horizon that we look at, because we think advanced SCCs can be just as deadly as melanoma, and the deaths per year of advanced SCC are actually higher than melanoma. So.
And in metastatic disease, so you mentioned, obviously advances. Anything specific there in metastatic disease that is intriguing you or just, making you on the lookout for that might actually lead to significant advances?
I mean, cell therapy is something that's, coming on the horizon. And I think that, it's a really interesting treatment modality. The same problem with cell therapy is that access to cell therapy is going to be really limited to academic centers, and it's a really intensive and laborious process that's only, probably appropriate for a certain patient population that's pretty fit. But we have all these clinical trials now looking at different drugs to overcome, immunotherapy resistance, other targeted agents, ways to combine things, ways to sequence things, ways to combine things with radiation, injectable agents that are new, utilizing viruses. So I think the future is really bright.
And then I want to shift just a little bit to non-skin cancer. In fact, Farah and I were having this conversation offline about a month ago. I was because I was asked by a colleague of mine about a disease that is not cancerous, and I'm going to slaughter the name, Farah, but suppurative hidradenitis, right? Did I slaughter the name?
Oh, hidradenitis suppurativa. Yes.
Okay, well,
Abbreviated.
it was close.
You
Like,
were close. Yeah.
yeah. So what's that for the non-physician in the room or in the audience, non-medical professional? What is that disease?
Yeah. So in layman's terms, it's like boils or what looks to be boils that arise principally in an area of certain glands that we have on our body called apocrine glands. So they tend to, these kind of boils or nodules can arise like in your armpit area, groin area, buttock area, and even frequently like in the underneath the breast area. Um, the causative factors keep going back and forth, but principally where you're going to see those boils is in those particular areas. It affects women more than men, and it disproportionately affects the Black population. So definitely you can see cases and I have seen cases in Caucasian men, but you're going to see more of this effect like Black women. And so the therapies that are there for this disease are,
So,
I
but
mean, they're not curative.
to pause a
Oh yeah,
little bit,
yeah, yeah,
this is a different scenario. This is because the squamous cell and the basal cell and the melanoma, we believe
yeah,
they're more common in Caucasians, maybe because sun
yeah.
exposure. This one is completely the reverse.
Completely the reverse. Yes. And under recognized and diagnosed and usually treated in much later stages.
Is there a reason why it happens? Is there some genetic component to it or predisposition in it that happens in African Americans more common?
Yeah, it's there are several researchers, particularly in more urban areas. So I'd say San Francisco, Chicago, New York, that do study this disease. There are no causative factors that have been identified at this time, other than like we believe that the disease is based upon the apocrine gland, and it goes back and forth if it's actually the apocrine gland or the hair follicle. So it's not like we can predict, oh, you're going to have this, and we don't know why the people that have it actually have it. So just based on the types of patients that come in with the disease, we could be descriptive, but as for more driving factors, there's nothing that's consensus based at this time.
So you don't see these patients, I presume, unless somebody thinks they're cancers and they come to you. I don't know. I mean, when I was I didn't do melanoma, but I don't recall seeing these patients myself.
Yeah, I actually have a couple of patients with this condition, but their condition is really bad. I mean, they have like, sinus tracts and like really bad scarring everywhere. And I see them because they have this area of chronic inflammation, related to the hidradenitis suppurativa. And in some, patients, when you have an area of chronic inflammation that, creates a good environment for a squamous cell skin cancer to develop. And so, some of those skin cancers I end up seeing because they can be really aggressive and because they're associated with chronic inflammation. And those patients don't really respond very well to immune therapy that we've seen. So, and this often happens more in the African American population, as Farah said. So, a lot of my patients, this is how the African American population gets these type of skin cancers. It's not always driven by the sun. It's driven by some type of chronic inflammation. And so I do have a couple of these patients.
Interesting. So how do you treat those, Farah, like the hidradenitis suppurativa?
Yeah, so from very basic to very advanced, I mean, dermatologists will often start with topicals like benzoyl peroxide or clindamycin lotion, but I can't say that they do very much when someone actually has active lesions or the boil type lesions, not the tunneling type lesions or fistulas yet. We treat with intralesional Kenalog, so injecting a steroid into the area, trying to drain the area. And then also now we'll try and surgically excise the area. That's been known for a long time, but the area can still recur even if you're excising all the apocrine gland area, and that's not really understood again why it recurs. The only FDA approved therapy we actually have that's an injectable is Humira. So people have heard that for psoriasis, but it's actually FDA approved for hidradenitis suppurativa. That helps to suppress the inflammation. But it's not going to actually, it'll prevent any new lesions from arising, but it's not going to, the tunneling or the fistulas that Sue was talking about, it's not going to necessarily help with those. And Humira is not curative. It may improve your quality of life while you're on it, but it's not a curative treatment. So there's a lot still to be done.
Do you give it lifelong or a time-limited therapy?
So usually I've done it as a time-limited therapy, giving people breaks, and we'll restart it if needed. A lot of times when people have really, really horrible disease, I'm doing it almost as a bridge to get them to surgery to have the area excised. I will say it's one of the saddest diseases. I think, obviously, and rightfully so, we give cancer a lot of attention, but with hidradenitis, I've seen women lose their jobs because they can't go to work when this area is draining, when it's purulent, when it's smelling. They can't sit, they can't move a lot of times. So it really, there's not just like a discomfort, it's like a complete loss of your life in a lot of ways.
How common is this? Like is this like very common, rare?
I think that it's almost difficult to answer that question because it's under-recognized. So a lot of times people will just come in and say, oh, I've had these boils, and they've been diagnosed as like a staph infection repeatedly. And so I think it's really hard to get the true incidence and prevalence of it, just because it's misdiagnosed as so many other things for so long and not really recognized until much later. It's common enough that every urban area I've lived in can have a once a week hidradenitis suppurativa clinic that is filled, and you probably still aren't seeing all the patients truly affected by it, because someone really has to really understand, oh, this is a mimicker of like a MRSA infection, and recognize it and send it to a dermatologist for continuous follow-up.
So do you see these patients because you have to give them the infusion of Humira because the dermatologist may not be able to do that, or is this given in the dermatologist's office?
So it's an at-home injection, right? So
I see. Okay.
Yeah.
Yeah. Okay. Well, but the dermatologist prescribes this, and so you see those because of the possibility of secondary malignancies that occur because of the inflammatory environment around it with the squamous cell and all of that.
Yeah.
Yeah. What are the chances that patients do well with the for the hidradenitis suppurativa with the treatment?
Most of them do very well, but again, it's not curative. So it's something that if it's not curative and it can rebound, and there's we tell people lifestyle factor changes, but honestly, I've seen patients very committed to lifestyle factor changes, and I don't really see a difference. I think the one that we've seen the most that could make a difference is to stop smoking when people smoke. However, I've seen numerous patients with this disease who don't smoke. So what do you say? It's also been said, oh, it's weight-based to lose weight. I've seen patients with BMIs that are very low that still have this disease. So I don't think we're at a point where we know that there's nothing curative. Humira can make it better. There can be development of resistance to treatment, and there's not a ton that's actually done to invest in this disease, which is really sad. There are definitely researchers out there looking, but the options, they're limited in a way. Like there's things that we can continue to do to help them manage it, but it's really managing a chronic disease.
So in the last few minutes, I want to go over, and then I'll let you go. I know you both are very busy, but I want to unanswered questions. So I want to try to if somebody is listening, they will think, what's going on from a researcher perspective, put on the researcher hat. What are the unanswered questions in early melanoma, in metastatic melanoma, in basal cell, squamous cell, and in hidradenitis suppurativa? So I'll start with you, Sue. What are the top 2 or 3 questions that you guys are working on in the medical oncology field for early and late stage melanoma?
For late stage melanoma, it's always trying to figure out, the best treatment for immunotherapy, refractory or resistant. That's a big problem. And there's lots of clinical trials trying to take a look at that. For early stage melanoma, I think we've, made a lot of strides in bringing the drugs, in the late stage to the forefront. I think a lot of people now really struggle with, is this treatment going to actually help me live longer? And because a lot of these drugs also do have side effects, and some of those side effects can be permanent. And so when you want to consider a drug that could have that type of side effects, you really want to make sure it's benefiting the patient. So I think, there's a lot of mixed feelings around adjuvant therapy for earlier stage disease, like stage 2 disease. But I think something that everyone is really working on is really trying to help the solid organ transplant population, especially if they have really advanced skin cancer, because unless you have a kidney transplant, you can't really get immune therapy because you have a high likelihood of killing your graft. And I have plenty of patients who have kidney transplants who tell me I'd rather die than go back on dialysis. And so really trying to find new treatment options for them that are not chemotherapy, that are also not immune based, is really important.
So just to sum this up a little bit, so you mentioned something interesting, the patients who are resistant to immunotherapy in metastatic disease. Anything we should be on the lookout for in terms of, is that the cellular therapy you're talking about, or is something else, some other modality we should be on the lookout for?
I think there's a lot of stuff on the horizon right now. It's always combining some drug with the immune therapy to try to, increase the response, either by altering the tumor microenvironment or, making the cancer more immunogenic if it wasn't considered immunogenic before. And so hopefully we'll see a lot of those trials, pan out and, get registration with the FDA. The cell therapy is mainly like, a treatment for, if you do have progression on immune therapy. But it's really for a select patient population because of the, how time intensive and labor intensive and access that's really needed to give that type of treatment. But that's something that's also coming out on the horizon that, will hopefully benefit a fair number of patients.
Or anything on the horizon for the BCC and the SCC, the squamous and the basal cell?
Yeah, I think I think people are really
or the unanswered questions kind of thing.
Yeah. I think from a dermatologist perspective, we're always, is this cancer? So once we know it's cancer and we know that it's beyond, the first line therapies we send to sue, and the oncologists have to really wrestle with what's the right therapy. But I think from a dermatologist perspective, we're wrestling with, is this in fact cancer? Is this a, mole that looks a little weird, or is this truly cancer? We focus on that when it comes to Spitz nevi in children. Is this really a melanoma, or is this a benign Spitz lesion that we can just take out? I think the other thing we also struggle with as dermatologists is, it would be nice if there were an easier way to tell if this was going to be metastatic to the node or other organ. So we could also, instead of having to send people for another procedure, it would be nice to be able to say, yes, you're the one who needs closer follow-up. I will surveil you more often. And what kind of surveillance techniques can we use other than just our naked eye and a generic LDH test? So, and that goes for both melanoma and for squamous cell carcinoma. Those are the two big things that I think we always come across, this, particularly when we're seeing these solid organ transplants or patients with hematologic malignancies or transplants for that reason as well. Patients with like CLL or other immunosuppressive hematologic malignancies, it'd be great if we could actually find ways to say, yes, this is worrisome and I should surveil you more often.
Yeah. Any unanswered questions in hidradenitis suppurativa?
Oh my gosh, I probably could take a whole other podcast for that.
Well, you'll get only 60 seconds.
It would be great if we could support more research as to what the causative factors are. It would be great if we had more therapeutic options in general that were more meaningful. I think Humira was obviously a great breakthrough, but other than that, there's not a ton. So if we could have more options and more definitive options, that would be great. I think we could give a lot of people their lives back.
So anything I should have asked you? I think what I've learned over the past 45 minutes is there are clear disparities in incidence. That's what I learned. I didn't get the impression that we know if there's a clear disparities in outcomes, although I think, Sue, to your earlier point, that there may be some research needed on this because we don't know yet. But I do think it's rather an intriguing area of research that hopefully we'll have answers for that. Anything else you need to leave our listeners with that I may have failed to ask you about? Sue, we start with you.
No, I think you covered everything really well. I just want to highlight that, we've come a long way, but we still have a long way to go.
Yeah. Farah, any thoughts? Anything I should have asked you?
No, again, I concur with Sue. I think you covered everything really well. If anything, I think in the US is the ideal place to do this disparities research because luckily we have different populations of people from all over the world. So why not start here?
Well, Dr. Spark and Abdullah, thank you so much for coming on Healthcare Unfiltered. Really nice to talk to you about this. I think there's a lot of advances, a lot of things that we need to work on, but it's hopefully this was a nice primer for listeners and viewers about the variations in skin diseases, because I can assure you there is a misconception that these only happen in a particular population. And I think hopefully we shed a little bit of light into the fact that this is not the case. And there's a lot of things that are ongoing. And hopefully the next time I have you on, we'll have more research that has been done over the next few years. Thank you so much.
Thank you.
Thank you.